Thank you all for coming. For Arnie Hassan and crew out in Lewisburg, thanks for being there. And for if there's anybody at CAMC, thank you for joining us. Cecil Pollard is my director. Whenever I was interviewing for my position about 10.5 years ago, he asked me, how do you feel about travel? And I should have known then that I was going to be spending a lot of time on the road, and rightly so. Most of the work that I do happens outside of the Health Sciences Center, and the information that I have to share with you is reflective of the primary care center partners that we've been building over time. So Cecil basically sent me out with a mission of find out the capacity of primary care centers to collect and use data to tackle some of the most prevalent chronic health conditions in our state. A lot of the work that we've done has centered around diabetes, cardiovascular health conditions, and asthma. So our objectives are really short and clear, I hope. I'll give you a 60-second overview of what we've been doing around the state, and then I'll provide you with one good example of how we've been applying electronic health record data to a public health initiative. I was looking at our contacts database this morning before I came in to see, putting this presentation together gave me a chance to be reflective about things a little bit. And I wondered, well, it's been over 10 years. How many contacts have I had with primary care? And as of last month, we've logged over 12,000. So those have been support sessions all geared around helping these rural clinics make better use of the data that they have and figure out what gaps they have in data collection, what the problems are, how to overcome them, how to use data once they have it. So that has taken a lot of time, a lot of effort, and a lot of trust building. Currently, we get de-identified data quarterly from 34 of these outlying clinics, so a very different population than you would find in IDR, but the example that I want to share with you about using data is hopefully very applicable. And I think with the IDR, you just need to be creative, I think. Think about what data are there, how you can use it. The idea of hypothesis generation is really cool. I've never looked at data that way before. Maybe it's because I'm always in a crisis mode with the sites that I work with. But overall, we provide a lot of support in tracking and reporting on key chronic disease indicators. Things from National Quality Forum, Physicians Quality Reporting Initiative, a lot of standard metrics in helping these sites take a look at the care that they're providing, and then do something based on their data to inform practice and policy changes internally to make improvements in their outcomes. And I'm glad to field questions as we go. This is a bit of a jump from Jeff's presentation, so I want to be sensitive to that. So the one example that I want to share with you, historically, most of the work that we do, pretty much all of the work that we've done, has been geared around patients that already have diabetes, that already have hypertension. So with the onset of EHRs and the uptake of these systems in primary care centers, there's a lot of opportunity to use those data for prevention. So we have a publication that is just coming out in Perspectives in Health Information Management about using EHR data in primary care for efforts in prevention. And I want to share some information about that with you. So we've done this work with the West Virginia Bureau for Public Health. This particular project was primarily funded through NACDD, the National Association of Chronic Disease Directors. The aim was pretty simple: to help facilitate diabetes prevention in a way that was easy for the sites to embrace and sustainable. Our approach was to use the data that they already collect day in and day out as a way of monitoring their patient populations more closely, with a big focus on being time and resource sensitive, because we're talking about health centers that are generally strapped for time and resources. And if you can do something that's going to help their patient flow and their outcomes, they're all for it. And if it doesn't fit in, they'll show you to the door. So methods briefly, and I can talk more about these as you have questions, but these sites don't all use the same electronic health record. So we needed to find an easy way of standardizing those data into one common format so that at least here at our office, we could take a look overall and see the problem overall. So we standardize the data and then provide the sites with tools that they can do these analyses internally, clinical decision support tools, so that they themselves can run these reports regularly on their own patient populations without necessarily my help. So we help them, first identify who is established, who's active, who's coming into your clinic. Then among those patients, who already has diabetes or pre-diabetes, and for this purpose, set them aside. And then among the rest of the patients that are left over, who has risk factors for diabetes. So looking at things like Jeff talked about, having access to demographics, health conditions, vitals, medications, services that these patients have received. Those are all important factors that go into building an algorithm like this. So helping them look at patients that are older and heavier in terms of BMI, patients that are younger but have a high BMI and various comorbid health conditions, and then also looking at some blood work. So what we ended up with in the 14 primary care centers that we partnered with on this initiative, so they have a little over 130,000 active patients total. Among those, you have about 106,000 that are actually established and active and have a consistent flow of data that they're coming in. We looked at those established patients, and then among those, we looked at those who did not already have diabetes or pre-diabetes, as indicated by their problem list, their health profile, and other things that we can weed out of free text notes. So we did some natural language processing also to find that patient pool. So this use of electronic health record data is just looking at those 94,283. What we end up with is a site-by-site comparison and an overall look at, let me use the mouse here. So the main column to look at is this sum. So here's your total potential patient pool, 94,283. Among those, 10,673, about 11.3%, have good indication of being at risk for diabetes. They don't have it yet, but they might very well soon if something's not done. So among that pool in each of these sites, we've been doing quality improvement initiatives to help them know who those patient pools are and do something about it. 4 of these 14 are trying to implement the National Diabetes Prevention Program, which is a pretty intensive endeavor for their patients that are taking part. And for the others, at the very least, we want them to be aware of the risk and to start to think about changes that they can make in their processes to look more closely at these patients and do something with their electronic health record data. Overall, the point is you can use electronic health record data for efforts in prevention. It takes some work. I think with the IDR, you have a lot of the groundwork that we've had to piecemeal together. A lot of that's taken care of already, all in the background, and it's really neat package that you have to work with. But in primary care, in these clinics, currently it's a little bit more unruly than that. So most importantly, I think what we're offering is of value to the clinics without them having to do any additional collection of data, which makes it more manageable for them. And there was a presentation recently on meaningful use. I didn't make it to that. But the gist of meaningful use is that you have a certified electronic health record and you use it well among your patient populations to make the care that you provide more safe, more effective, and just overall that you have the chance to use an EHR to improve our health outcomes. So this can help our partner sites demonstrate meaningful use of the data that they have being collected day in and day out. I think what I really wanted to say here was that while data are shared back to our office for overall evaluation and analysis, what we really try to do is push out tools to these primary care centers so that they can do these things internally, build up their own skill set among their providers and staff, that they're confident in knowing how to look at their data, what they can do with it, and have just improved self-efficacy around knowing what data they have available and how it can be used in-house pretty easily to help improve their health outcomes. There are lots of interesting things that happen along the way with using electronic health record data. I just picked 3, and the last one is a shameless plug for one of our other publications. But there's Hirsch just put out a nice, clean document about caveats for using electronic health record data, things that you would likely encounter along the way. There's also a lot of literature out there about thinking about using routinely collected data for research, and I think those things are very applicable to what the IDR offers to you. And shameless plug, a lot of what we do has centered around data quality in the analyses that we help these sites put together, so that's a big deal. What kind of questions do we have? Arnie.
We have a question here. How easy it is for one of our researchers to be able to get data out of your CRDEB database? There seems to be some concern that it's not all that easy to start asking questions and getting the data.
Okay. What kind of, are you talking about a clinic looking at their own data in-house?
No.
No?
We're talking about anything that ranges from getting our own clinical data to getting a sense of what's going on in the state so we can talk about research projects or potential projects.
Has anybody asked me? I don't think there's any concern about that. Cecil, you can help me out, but I'm all for it. And if there's any concerns, I'm glad to address them. And we're certainly not holding anything back.
I'll be full of smile and we'll be in touch.
Okay. And you're also laughing. That's scary. Folks here, you have some questions? Yes, Emily.
I was wondering if any of the clinics have used this information to try to quantify the impact in terms of cost reductions over time.
Not that I know of. A lot of them have used these data to apply for grants. But in terms of like an ROI, return on investment analysis, nothing that I'm aware of. Cecil, do you know of anything?
No, but we don't have the financial data tied into this.
Oh, that's true. This is all clinical. So being able to bring cost, and like Dr. Coben brought up the idea of associating cost with the IDR, seeing that it's linked to billing, I think you could do that sort of analysis through the IDR ultimately, which would be a big impact. We're more limited in terms of what we can offer through this chronic disease registry. Yeah?
So your data is mainly about chronic disease, or you have all the chronic disease and what variable? What are the general variables?
Well, the registry that ultimately comes back to us is chronic disease specific. However, there is lots of opportunity to expand that to other conditions. Dr. Coben's my dissertation advisor, my chair, and one of the main thrust behind what my dissertation is going to be is using a similar model to look at falls, accidental falls risk identification, and doing something with primary care to use routinely collected data to hone in on patients that are at risk for falls. So same model, completely different arena. But did I answer your question? We have, the data we have coming in are similar to the IDR, not as comprehensive. We have demographics, visit information, so vitals, health conditions, labs, services that they've received. So medications, yes, thanks. If that's something that the sites want us to map it's included in their electronic health record, then yes. But a lot of what we do is all participatory driven, so we have access to that, but it's not something we've looked at yet. Dr. Shrews.
How did you get buy-in from the centers? Did you actually physically have to go and talk to them, or was it word of
Yes.
mouth?
A combination of both. At the outset, it was lots and lots and lots of driving. After a while, once I became a little bit more accepted and known, word of mouth helped. But I was looking at the number of trips we've taken out of those 12,000 plus support sessions, and we've had about 10% of that has been driving, so about 12,000 trips. So I'm with the practice-based research network that's forming through CTSI. What I'm hoping, what makes sense is that the partners that we've been able to build over the years, this map, that we build on this and allow the PBRN to grow, substantially, hopefully fairly quickly. Did that answer your question?
Yeah, because I'm in a situation where I have an Alzheimer's registry that's state mandated. Once you mandate compliance, all those dots go away.
Yeah. All of this is totally voluntary. I can see it. Yeah, I see that. Yeah. Anybody? Arnie, I can't see you, but I'm looking at you. Any more questions?
Arnie has left the building.
Oh, okay. For the folks
Any
here,
other questions? We're good. We don't have any other further questions.
is there anybody, thank you for that. How about CAMC? CAMC, I don't know if anyone's there, but I'll pause for a moment and see if you have some questions. Okay. Dr. Coben?
Hi, we're here, but we don't have any questions.
Okay, thank you. Dr. Coben?
I have another question back to IDR. Emergency department visits. Obviously, they're included in the but are they included in the IDR and then what do we use prior to being able to incorporate outpatient emergency department visit data in the IDR also?
The information we have prior to the Merlin onset was from MedSite. So the other information we have is we pulled pretty much the entire MedSite database over. So the other information we have is if it was in there, it would be in the IDR as well. So the MedSite information went back to 1995. So that's for that we have the demographics, the diagnoses, procedures, and the lab results, just minus the medications. So I'm not entirely sure. I think it would be included. Okay. I couldn't remember on that because there was a separate system, I think. So if it was in MedSite, it would be in there. Yeah. But it's one of those things, if the data was out there in a different system, potentially we could pull it in. And if it was something that you needed, it's a possibility. So we're able to pull it from different systems. We've had, one of the things I didn't mention was, that may be of interest to some people, is one of the hot topics is to include tissue bank data associated with the IDR as well. So that's one of the discussions that's up, to incorporate that in there so that you can view that same information and know how many of those patients have tissue samples available. So, or to be able to search that information to view what's there. So that's, we'll continue to add data sources to what we have there, but that's currently the point we're at right now, is with the WVU Healthcare Merlin and MedSite systems. But some of the other hospitals will fall in pretty quickly though. So and we do have, currently we have 1.4 million patients in the repository. We expect that number to rise pretty quickly as we incorporate other hospitals in. And we do not have the mortality data, so a lot of those patients could be deceased. We don't know. So when you start doing the numbers, how many 1.8 million in this people in the state, and we have 1.4 million, we don't, you know. So some of those may be from Pennsylvania, but but the numbers should grow pretty rapidly.
You don't have outside mortality data, but you have disposition data from the hospital. So if someone died in the hospital, you should be able to capture that.
If it's captured in Merlin.
It's in the building.
Okay, if it's in the billing data, then yeah. I don't claim to be an expert on all the different codes, and so we're database geeks. So essentially, we're able to get the information from one place to the other. It's up to you guys to make sense out of it. Yes, Bernie.
You're a geek.
Yeah.
You said IDR has just gone live relatively recently. Does the IRB know about the IDR? And if not, have you spoken to them?
We've got one of the
Yes,
one of the members right over here. Yes.
we actually had extensive discussions on the IDR preparation for these issues to make sure that they're in full compliance. I think it's quite fair to say that you've asked many questions because you want to be in full compliance.
Yes. One of the other things we've undertaken is the legal agreement we have with the hospital here, and we'll have with the other data sources that we have. That whole process took over a year to get the whole legal agreement worked out so that we can utilize the information and use it for research. So, yes.
In terms of the IRB, is there a standardized format, something that lets us do easily accessible requests through the IRB? Is that an exempt? Our current system is somewhat detailed.
Right. Okay. So our process won't be anything different than what it is currently right now. So you'll still do the same process with the IRB as you currently do. So once you get that approval and get all that worked out, if you need identified data, then we can pull it for you. But we're really not going to be involved with the IRB process.
Okay, but the part of it is the HIPAA waivers request. So what you have would allow us to say that we would be eligible for HIPAA waiver if we got it from you, de-identified.
Now, so
Steve.
de-identified doesn't require HIPAA waiver.
Okay.
It's stripped of all 18 identifiers, and you can get a non-human subjects research designation. If you want identifiers, then you're looking either at the exempt category or
Thank you.
Chuck?
I was just going to say to the group that, at least as I understand it, interacting with the IDR, because it's de-identified, nobody needs IRB approval. And that's one of the reasons he can't show you if there's only one patient in Hillside County, because then you could possibly know who that person is or what have you. So interacting and getting your numbers and playing around does not require IRB approval. If you find that there's 150 patients of interest for your study and you want their names, you can contact them or to dive into Garland or what have you to pull up more information. That's where you need to go get IRB approval and submit your request.
To do a preliminary search, like how many patients would one be included?
Exactly.
Okay.
That's the whole purpose.
Yes. And we're talking about different data sources and enhancing the web application that we have there. 1 year, 5 years, 10 years from now, I'm not sure exactly what's going to be on that web screen, what we'll build into it. But the one thing I can guarantee that won't be up there is identified data. So we will not be showing identified data through that web browser. So we do have the identified data, and we can get that for you. We have access to it, but it won't be displayed through that application. That's something we'll have to pull for you manually once you have your IRB approval. Yes?
Just a comment. We talked a lot about using the IDR for hypothesis generating, but going back to the statisticians in the audience, time series analyses can be used with these data for hypothesis testing purposes directly. So I don't necessarily just use this as hypothesis generation. If you have an idea, they've got policy or organization patterns in the community, you can actually test that hypothesis using these data over time, assuming there's no changes in quality of the data, etc.
Yeah. You-
Comment on that.
Yeah.
I'll just grab this.
Okay.
So I think one underlying theme from more of a statistical point of view that's been touched on but can be really exploited by researchers here is that sort of this the secondary use of databases that are being collected to answer other health-related questions really has two pieces to it. So there's the hypothesis generation part, which I think is an absolutely brilliant way to use such databases because it can give you insights into possible questions. And then you can go off and do grant applications or design studies based upon some observations that you're making within the databases. The second one, which Dr. Coben has touched on, is to actually do hypothesis testing using the databases. So setting aside all the nuances of using doing secondary data analysis on a database, the fundamental concepts are the same, and I think the databases provide opportunities to look at trends over time and to identify possibilities for when there could have been a policy or a change, let's say, is extraneous or due to the system. So I think a good example was the one we had with the trend here, where the comment was, was there a change in the billing that was going on that caused the increase in trend? And so you have the opportunity to ask questions like that. If you can eliminate those questions, then you've got health-related questions left over. So I think that those are two themes which are really brought up quite nicely in this presentation. So I think the common, one thing I've seen from secondary database analysis is that we often move back and forth between hypothesis generation and hypothesis testing to back to hypothesis generation and then back to hypothesis testing when we're using these databases. Because as we, for lack of a better word, mine the information there and discover new relationships and new ideas, they're going to always be generating new hypotheses and new questions to go on. So it's really a dynamic process. And I think probably Adam could probably agree with this, that it's a very dynamic process. It's not just design, measure, answer, but you're back to design again, always. It's kind of my perspective, I think. Cool.
Okay. Since we have a couple extra minutes here, one of the things I didn't describe, but speaking of the statisticians and the general researcher as well, is this part right here, which we've referred to as our data mart server. So we have set this up specifically. This is our main database here with identified information in it. This is our de-identified database. But we have this data mart server. It has 17 terabytes of usable drive space on it. So our idea there is, as we distribute data out to researchers, we're going to move it to that repository there. And this, you can see up here, the statistician or whoever can connect with their stats client, their SAS, their R, whatever, directly into the data mart server and pilfer through the data and run whatever analysis they need to. We can move over large data sets over to here and they can just connect directly. So any of this information from this CRDEB database, the 6,000 tables of information, we can do that pretty easily and make it available for the statistician or whatever researcher needs the data. So, and we have a new web client that we're developing right now that will allow you to do some data collection and data analysis, graphing, things of the such, connecting to this data mart server. You as the researcher will be able to log in and do this. These are things we're working on right now, but it's not ready to go live yet. So in the near future, you'll hear more about the data mart server. But that's part of the idea, is to enable the statisticians and everybody to analyze their data and view their data directly within the database without having to move it out there. So the other part of that actually is the security. So right now, currently, in a lot of environments across the country, if you request patient information and you get it from the medical records department or whoever, they generally will email it to you internally, not externally. But they'll, it comes in an Excel file, and then where does it go? It sits on your desktop. So you're in an unsecured part of the building. This is pretty common. So it's, there's patient information all over PCs all over the country in different offices that are not locked. So our idea with this and setting up the data mart server for our data distribution mechanism is that we will move it to that database and you'll be able to connect to it there and not have to remove it from that database. That database is in a secure data center over at the hospital's ROC, they call it the ROC, Ruby Office Complex, and it's housed there. It's behind locked doors, swipe cards, and all that kind of stuff. So basically, it's the security part is a part of that too. So, but that's coming very soon, and you'll hear more about the data mart server in conjunction with the IDR.
So I think we've learned quite a bit about what's going on the database end of things. I just want to say thank you to Jeff and to Adam for coming and sort of giving us a nice high-level view and some of what's going on and the things that are at work through CTSI and also surrounding CTSI and researchers here. So join with me in thanking them, and I think that concludes this week's.